Thank you so much, Camilla, for the nice introduction. Happy to be here. Don't worry about your Dutch. My Swedish is limited to tack, skål, and systembolaget. So happy to be here and indeed to share some of the insights that have been built up in the congenital heart disease community regarding neurocognitive and psychological outcomes in adults with congenital heart disease. And I'm well aware that most of you are not directly working with people with congenital heart disease. So let's start with a very brief introduction. Congenital heart disease basically has to do with structural abnormalities of the heart or the great vessels. And they have an actual impact on functionality or a potential impact on functionality. And obviously, it is present at birth. It's not always diagnosed at birth, but it is present at birth. How often does it occur? Well, worldwide, the birth prevalence of congenital heart disease is 8.2 per 1,000 newborns. So, which means close to 1% of every newborn has congenital heart disease. These are global numbers. There is some variation across the different continents. For instance, the highest birth prevalence can be observed in Asia, with a birth prevalence of 9.3 per 1,000. And in Europe, it is 8.1 per 1,000 newborns. So it is not a rare disease. It is not a minor thing. It occurs quite often. It used to be a lethal condition. However, due to operative techniques, due to medical management, nowadays more than 90% of people born with congenital heart disease can make it into adulthood. If you bring in the bicuspid valve, then even up to 97% can survive into adulthood, based on Swedish data. So that means that we can give a lot of life prospects to these patients, and that is fantastic. How does this look like as a population? Well, the birth prevalence, the 8.1% in Europe, remains relatively stable, which means that the number of children with congenital heart disease remains stable as well. However, due to the increased life expectancy, the number of adults is growing, as you can see here. And what is a fascinating observation now is that we see an increasing group of people with congenital heart disease in their 60s and beyond. So the red group here, adult congenital heart disease patients over the age of 60, is growing. And it is estimated that by 2030, which is actually in only a few years, that 11% of all people with congenital heart disease are 60 years or older. We know that this is coming, therefore we need to be prepared for this new group of patients in congenital heart disease. Another thing that is important for you is to know that congenital heart disease is a very heterogeneous group. We have very mild conditions, we have moderate conditions, and we have very complex conditions. And there are lists which condition belongs to the mild, to the moderate, and to the complex group. It would be beyond the scope of this presentation to go through this list, but know that these exist, and you can have a look at this paper if you are interested to see. I have a patient with a transposition of the great arteries. What kind of condition is this? What is the level of complexity? Like I said, congenital heart disease is present at birth, but it is the start of a journey. And even if patients are treated when they are child, they are not fixed. They start with a trajectory of certain issues, certain problems that occur throughout their life. They remain, even if the structural abnormality is kind of corrected as much as possible, they remain vulnerable for developing complications such as heart failure, such as arrhythmias, hypertension, and so on. And therefore, they need lifelong follow-up because we want to anticipate on the complications. It's not only medical complications, also complications or issues in terms of well-being, in terms of psychological outcomes that matters in these patients. And that is exactly the topic of the presentation today. So I have two parts in my presentation. First part has to do with neurocognitive functioning. The second part with psychological outcomes. They are related, obviously. Neurocognitive functioning. What is important to know is it starts at birth and even before. We see that a lot of the children, well, I should not say a lot, but quite some children with congenital heart disease present with neurodevelopmental issues. This persists during their childhood and during adolescence. I will not go into the details of this because I leave that up to the next presenter. Carmen will more touch upon this aspect, how it emerges in clinic and what you can do in clinic. But know that it starts from the beginning. And whereas the neurodevelopmental issues are decreasing over time, no developmental issues occur, but by growing older, there is more an issue of acquired conditions. So neurocognitive dysfunction, but from an acquired perspective, is occurring while people are getting older. So it is actually kind of a accumulation of problems that were there at birth, and then on top problems that come with aging. When you look at the neurocognitive function of adults with congenital heart disease, well, there are some risk factors. Risk factors that are not as much seen in the general population. People with congenital heart disease are prone to develop atherosclerosis, diabetes, hypertension, atrial fibrillation, and heart failure. And these risk factors in itself play a role in developing neurocognitive problems. There is, for instance, a reduced cerebral blood flow that's objectified in several studies. People with congenital heart disease tend to have, and especially those with complex conditions, they tend to have reduced brain volumes. So you can objectify this as well. Obviously, there are social consequences of the brain injuries in terms of employability, insurability, quality of life, and so on. And even dementia is a thing in congenital heart disease. And when I heard this for the first time, I thought like, is this really true? I mean, from a theoretical point of view, I can see that, but is this really true? Well, the first study on dementia, or risk for dementia in congenital heart disease, came from Denmark, large-scale study, and they found that the rate of developing dementia in congenital heart disease is 60% higher compared to the general population. When you look at people with mild and moderate conditions, it is 50% higher. So it is also in people with mild conditions, you see an increased rate for developing dementia. And the early onset dementia in congenital heart disease is 160% higher. So yes, there is a problem regarding dementia in congenital heart disease. Here I'm talking about the diagnosis of dementia. Of course, it starts earlier and it starts in more subtle ways. And this is actually a poster that has been presented at the conference of the European Society of Cardiology last August. It is a study that we conducted in collaboration with 17 centers from 11 countries worldwide. And we looked at frailty of our patients with congenital heart disease and cognitive dysfunction. We included people aged 14 or older. So the youngest patients were excluded from that study, 40 or older. And the initial idea was to include only people with a moderate or a complex heart defect. There were 2 centers who didn't read the protocol very well, and they also included people with mild conditions, which is a violation of the protocol. However, when we were doing the analysis, we thought that the results were so important and so interesting that we decided to keep them in. So the data that I will present you are representing the entire group of people with congenital heart disease, mild, moderate, and complex heart defects. The cognitive functioning that we assessed, we used the Montreal Cognitive Assessment. This is actually a screening tool. That is the screening tool that also was used on President Donald Trump. And according to him, no one ever had such a high score on the Montreal Cognitive Assessment as he had. In terms of cognitive dysfunction, 39% of the patients with congenital heart disease had a cognitive dysfunction. 39%. That was amazing. We were really struck by this finding. What was interesting here as well is that cognitive dysfunction was related with age. Older age, more cognitive dysfunction. No surprise. More comorbidities is also related with a higher cognitive dysfunction. No surprise either. What was more surprising to us that it was not related to the complexity of the heart defect. Once again, also mild conditions had as much cognitive problems as people with complex conditions. To a certain extent, this is troublesome, and this was worrisome for us because you often hear, well, this is a mild condition. Yes, mild from a cardiac point of view does not mean mild from a systemic point of view. So it really is important that we learn more about cognitive dysfunction in people with congenital heart disease, that we try to get a better grip on that and see how we can mitigate the impact of that phenomenon. That is actually the part of the cognitive dysfunction. Still more to come in the upcoming years. Second part of the presentation has to do with psychological outcomes. And I would like to raise some attention for this paper. It is an overview paper that I published with some of my co-workers earlier this year, where we made a nice overview of what is known on mental health and mental health status in people with congenital heart disease, specifically adults with congenital heart disease. First of all, when we have a look at mental disorders, so it's not about the symptoms, it is about the real clinical diagnosis. Well, depression seems to occur in 0 to 27.3% of the patients. Broad range depending on how it is diagnosed, what type of patients that you have included, but when you look in the literature, it ranges from 0 to 27%. Anxiety ranges from 5 to 35 or 36%. Bipolar disorders One study, 0.7%. Post-traumatic stress disorder, 0 to 3%. Schizophrenia and psychosis, 1.4 to 4.5. ADHD, 1.3 to 33%. Autism, up to 3.2%. And eating disorders, up to 2%. So, mental disorders are prevalent here. And those studies that have a comparison with the general population are indicated here with an asterisk. So, asterisk here means that yes, it is confirmed that the rate of mental disorders in congenital heart disease is higher compared with the general population. Then the question is, okay, these are mental disorders. What about symptoms of mental health or ill health, I could say? Well, that problem is even bigger because symptoms are more subtle and not necessarily result or not necessarily associated with the disorder, but still they are there. And the question then is, these symptoms of mental ill health, to what extent are they related to well-being of patients? The question is not, is it related to well-being? Because the answer is yes, but to what extent is it related? And for this, I would like to focus specifically on a study called Approach IS. And Approach IS stands for Assessment of Patterns of Patient-Reported Outcomes in Adults with Congenital Heart Disease International Study. This was indeed an international study that ran from 2013 to 15, and it was conducted in 24 centers from 15 countries in 5 continents. The sample looked like this. Overall, we had more than 4,000 patients included. This is the gender distribution, and the median age was 32 years. The distribution of complexity was 1/4 mild condition. About half of the patients had a moderate heart defect, and 1/4 had a complex heart defect as well. Why is this important, or what can we learn from Approach IS for the presentation of today? Well, this is a model that those among you who are working with quality of life, they may recognize this model. It's the Wilson and Cleary model on quality of life, more specifically health-related quality of life. And it kind of theoretically explains how are things related towards each other. And for instance, there is a link between the biological or the physiological status and quality of life at the end. It is an indirect link. It goes through several steps, but there should be a link from a theoretical point of view. If this is a theory, we can test this with data from Approach IS, which we did. So we looked at the type of the heart defect and saw what is the explained variance, how much of the variance in quality of life is explained by the heart defect. And the answer is 1.1%. So if quite often cardiologists look at congenital heart disease from an anatomical point of view, and no one is to blame for that, but this has little impact on the quality of life. Even less when you adjust for the New York Heart Association classification, then you only have 0.4% explained variance. So there is really little that the type of heart defect is contributing to the quality of life of the patients. Of course, the question is then, are there other factors that play a role? For instance, the functional status. We just heard the New York Heart Association classification. If you enter that to the statistical model, things are changing. Well, the question is, what is the New York Heart Association classification explaining? Well, 10% of the variance in quality of life is explained by functional status of the patients. It's not the anatomy, it's the functioning that matters to the patients. And if we bring in even more aspects, for instance, characteristics of the individual, certain socio-demographic factors, what we found is that not only the self-reported New York Heart Association class, but also older age, job seeking, and not being married, they together play an important role in explaining quality of life, an important role explaining 19.5% of the variance, which is much better than the 0.4 of the heart defect, but still a lot we don't know, 80% that we cannot explain. So we need to dig in a bit further. In Approach-IS, we looked upon different patient-reported outcomes from different perspectives. We looked at medical, demographic, behavioral, social components and see what is explaining what and how big is this explanatory power. This presentation is about psychological outcomes, so I would like to address and specifically focus on these psychological factors. And there are 4 factors that are especially relevant and especially interesting for us. It's self-efficacy, sense of coherence, illness identity, and illness perceptions. Let's first look at illness perceptions. And this is, I'm sure, a lot of you are known with this concept. It is how people perceive their condition, what is the causes, what is the trajectory, what are the consequences from a patient's perception point of view. That is illness perception. When we related illness perception with quality of life, 16% could be explained, which is way more than the factors that we saw before. Sense of coherence. Overall, when you look at sense of coherence at this international study, it's 17% of the variance in quality of life that is explained, which is also pretty good. But interestingly enough, in such an international study is that you can also see what is the situation in the different countries. For instance, we looked at the explanatory variance or explained variance of sense of coherence on this scale, and we also looked at the explained variance of other patient characteristics on this scale. So doing so, you see 17%, it's here, but there are countries like Japan, Norway, Taiwan and Sweden where sense of coherence plays a bigger role in explaining quality of life. And there are other countries, including Belgium, Switzerland, USA, where patient-related factors such as having a job, being married and so on plays a role. This is interesting to see because it means that if you really want to improve the quality of life of your patient population, that you just don't have to go to the literature and say, oh, a study has found this and I adopt this, because it could be well that a study in Belgium focusing on maybe these factors is not having the same impact here in Sweden and vice versa. So you really need to go into the details to see what matters to our patients, what are factors that play a role in our patients. And data like this really helps you to understand this. Illness identity. This is a relatively new concept, but very fascinating. And it's still an evolving field. Illness identity has to do with to what extent is the disease, is the illness integrated in the identity of the person? To what extent is the person feeling as someone with this condition. And although this is still an evolving field, right now there are 4 dimensions that can be identified. A dimension of engulfment, so someone can be engulfed by the condition, overwhelmed, which means that the disease, that's me, and everything that happens in my life is due to my disease. That is engulfment. You have rejection, where people try to keep the disease out of their life. And this is not a very adaptive way of dealing with the condition, but they try to keep it away, not to think about it, not to deal it too much, just to do the absolute minimum of the disease. You have acceptance, where people say, well, it is part of me, and yeah, I need to deal with it, and I learned to deal with it. And finally, you have enrichment. And this is the situation where people say, I'm a stronger person because of my disease. This made me stronger. This helped me to grow as a person. It's not that you have to allocate people to one of these boxes. You can have higher score on different boxes. So you can reject and accept at the same time to a certain level. That is all possible. When we look at these dimensions of illness identity and see the relationship with quality of life, you see that engulfment, rejection, and acceptance is related to quality of life. We don't have the explained variance in this respect, but we see there is a role that is played. Engulfment is a particularly strong predictor for quality of life and even for other patient-reported outcomes. So, luckily, most patients are not engulfed, but those who are engulfed, they tend to have poorer outcomes in terms of patient-reported outcomes. Enrichment seldomly occurs, and it does not play a big role in explaining other factors. Self-efficacy. Self-efficacy means, do you think you are able to deal with certain challenges in life? Right? And the general self-efficacy had an explained variance of close to 10% related to congenital heart, related to quality of life. Let's bring all these things together. Remember the congenital heart defect, the type of heart defect, 0.4% explained variance. If we on top of that bring some patient characteristics, sex, age, ethnicity, education, employment status, marital status, and having children, that in itself, this block explains 5% of quality of life. But when we then bring in, on top of that, anxiety, depression, illness perception, and sense of coherence, clearly psychological outcomes, they in itself explain 36%. So when I'm presenting this kind of data to our cardiologist, I always say, well, I know that you are concerned about your patient's quality of life, but you as a cardiologist have little to do with it. There is little you can do to improve the quality of your patients, because it's more about factors that you cannot change, but the strongest predictor has to do with psychological outcomes, which means you need a mental health provider in your team. They will have the biggest impact on the quality of life of your patient. Again, these are data from an international perspective. The question is, does this apply for all countries? Does this apply for Sweden, for instance? Well, again, an international study helps us to understand or to do this analysis for the different countries, and look where Sweden is. These factors, these 4 factors, anxiety, depression, illness perception, and sense of coherence, together explain 51% of your patient's quality of life. Which means that if you take these as targets for interventions, you have the strongest impact on your patient's quality of life. If, for instance, Argentina would take that as a target for intervention, the net effect would be much lower than what you have in Sweden. And that's why this kind of data are so interesting, because it really can guide us what to spend our money on. What is happening with aging? Like I said, we are dealing with an aging population. Is there a relationship between psychological factors and aging? We had a paper that was published in the European Journal of Cardiovascular Nursing, again on Approach-IS data. The journal is now using graphical abstracts, so let's have a closer look at that. So we looked at physical functioning, mental health, and quality of life. Like I said, international study, but what we did here was we divided the 4,000 patients into 3 age groups, and the biggest group obviously was the group aged 18 to 39, then a group 40 to 59, and a group 60 years or older. And what we observed there was, no surprise, the physical functioning is declining with aging. But what was surprising was that the mental health, or the mental component summary, and more specifically anxiety levels, they were improving over time. So older patients with congenital heart disease showed to have lower scores on anxiety. It is indeed illustrated by this plot as well. Between the 2 younger groups, not as much a difference, but the group of 60 plus, the anxiety levels are somewhat lower. A question that I'm getting all the time then is, but is this a typical congenital heart disease phenomenon? The answer is no. Also in the general population, you see that depression levels sometimes are increasing with aging, but anxiety levels often are decreasing with aging. Maybe it has to do with wisdom, with the fact that there is less to lose when you are at older age. I don't know the explanation for this, but anyway, to a certain extent it is also comforting us that we see our patients are less anxious when they are growing older. And how to deal with this? What to do with this information? An interesting statement was published by the American Heart Association, I think it was last year. It was a consensus statement where people from different entities of American Heart Association came together and they developed the psychological outcomes and interventions for individuals with congenital heart disease statement. I really recommend have a look at this, because this is really interesting and important, because it indicates what you can do in terms of screening, how can you assess it, what you can do once that you have identified psychological problem, what can you do? What is the place of psychotherapy and the effectiveness of it? What is the place of medication treatment, and so on? Again, it would lead us too far today to go into the details. But the take-home message that I want to give here, based on that statement, is we strongly advocate for the integration of mental health professionals within congenital heart disease teams or the medical home, which is an American thing. Yes, that's true. We need mental health professionals integrated in the congenital heart disease teams. And when you look at the data and the impact that psychological factors have on quality of life, in Sweden, it is even more important in a Swedish context than in a non-Swedish context. So this is really something you have to bear in mind. I would like to come to the conclusion of this presentation. First of all, the heart-brain axis. It's getting increasing attention. These are two different organs, obviously, but there is a strong connection. And we start to understand this connection better and better. And also in congenital heart disease, this relationship, this link, this axis is getting substantiated much more than before. Neurodevelopmental issues in congenital heart disease are known. They start very early in life, like you will hear from Carmen, the next speaker, but it persists, it continues, and there is an additional burden by growing older, additional burden on the neurocognitive aspects. And indeed, this makes the problem just bigger in terms of neurocognition. There is a decline in adults, there are problems, dementia, like I said, is a bigger problem in congenital heart disease. Psychological problems are prevalent and they are strong predictors for quality of life. So we need to look at psychological or mental disorders, and we need to look at symptoms for mental disorders, but then the psychological problems like anxiety, like depression, and so on, they play a strong role in the quality of life of our patients. And finally, and that is really the take-home message, mental health professionals should be integrated in the congenital heart disease teams. Thank you for your attention, and I'm happy to take questions.